Explain the anatomical basis of internal and external hemorrhoids, anal fistula, vasectomy, tubal ligation, pregnancy, and tubal ligation. So in this we study the anatomical basis for these different things. Internal and external hemorrhoids. Hemorrhoids develop when the venous drainage of anus is altered, causing the venous plexus and the connecting tissue to dilate, creating an overgrowth of anal mucosa from the rectal wall. Hemorrhoids can occur above or below the dentate line. Dentate line is a place where the proximal columnar epithelium transitions into distal squamous epithelium. Anus is approximately 4 cm long in adults and the dentate line located roughly at the midpoint. Hemorrhoids developing above the dentate line or internal. They are painless because they are viscerally innervated. External hemorrhoids develop below the dentate line and can be painful when swollen. The exact prevalence is unknown because most patients are asymptomatic and do not seek care from a physician. Hemorrhoids are more prevalent in persons 45 to 60 years of age. Precise cause is not well understood. Hemorrhoids are associated with conditions that increase pressure in the hemorrhoidal venous plexus, such as straining during bowel movements secondary to constipation. Other associations include obesity, pregnancy, chronic diarrhea, anal intercourse, and cirrhosis with ascites, pelvic floor dysfunction, and even low fiber diet. Anal fistula. Anal fistulas have been a long-standing problem for patients. They were first described as early as 430 BC. Approximately 90 to 95% of anal fistulas arise from anorectal abscesses, and these are classified as cryptoglandular in origin. There is a clear relationship between anorectal abscesses and fistulas. 1/3 of patients with anorectal abscess will have a concomitant fistula at the time of presentation. Patients with recurrent anorectal abscesses have an even higher chance of having concomitant fistula. Several studies have shown that men are twice as likely as women to develop perianal abscess and fistula. In the normal anal canal, there are usually 6 anal glands that are distributed evenly and circumferentially at the level of dentate line. Glands communicate with the anal canal through crypts or ducts. 80% of anal glands are confined to the submucosa, and the remaining 20% may penetrate the internal sphincter but rarely penetrate external sphincter. As far back as 1880, Hermann Defosus hypothesized that some cases of anal fistula may be caused by anal glands penetrating deep from the lower rectal mucous membrane to the perianal tissue. This hypothesis is referred to as cryptoglandular theory and is strongly supported by the works of Parkes in 1961. Parkes concluded that the infected anal glands were the origin of anal fistulas in over 90% of cases. Vasectomy is a permanent method of contraception for men. It involves a minor surgical procedure where the vasa deferentia are cut and tied. This operation keeps the sperm from mixing into semen when men ejaculate. It is much simpler procedure than the female sterilization. As a birth control method, vasectomies are 99.9% effective. During vasectomy, a local anesthetic is used. The healthcare worker or provider makes a small opening in the skin of the scrotum. This allows the sperm tubes or vas deferentia to be seen and cut. This procedure itself takes about 15 minutes. Vasectomies are not immediately effective after operation. The sperm which was in the tubes before operation still need to be ejaculated. This may take about a month or 10 to 30 ejaculations. Therefore, it is important to use other forms of birth control until the remaining sperm are cleared from the tubes. Vasectomy is a permanent sterilization technique. In developed countries, reversal surgery is available but not always effective. Tubal pregnancy and tubal ligation. Historically, the overall rate of ectopic pregnancy has been approximately 1 in 100 pregnancies, but the incidence has been rising in recent years. For women who resort to assisted reproduction techniques, the frequency of ectopic pregnancy can be as high as 2% to 4%. In the general population, the previous ectopic pregnancy history of tubal surgery, documented tubal pathology, and in utero diethyl stilbestrol exposure are the major risk factors. Interestingly, risk increases proportionally to the number of previous ectopic pregnancies. It also decreases after an intrauterine pregnancy. In majority of the cases, implantation occurs in the fallopian tubes, that is 95 to 98%. But the involvement of vagina, cervix, ovaries, and intraperitoneal structures has also been well documented. Tubal ligation. Elective tubal sterilization may be performed via laparoscopy, hysteroscopy, laparotomy, or colpotomy. For tubal sterilization via mini laparotomy, either a vertical or transverse incision is satisfactory. Both incisions provide easy access to the fallopian tubes. In many instances, Fanstein type of transverse incision made approximately 2 to 3 centimeters above the symphysis pubis and approximately 2 to 3 centimeters in length is satisfactory. The fascia is divided transversely. The rectus muscles are retracted laterally. Transversalis fascia and the underlying parietal peritoneum is incised in a vertical fashion. To avoid bladder injury, the bladder must be adequately emptied immediately before surgery and an indwelling Foley's catheter can be placed. Colpotomy has historical significance and is an acceptable approach in selected patients such as those who are very obese, having a history of abdominal or hernia repairs. In this technique, the peritoneal cavity is entered through the incision made in the posterior vaginal fornix between the uterosacral ligaments. The incision may be either transverse or vertical and is made directly through the vagina into the cul-de-sac. Oviducts are then drawn into the surgical field and the selected sterilization procedure is performed. The colpotomy incision is usually closed in one layer with absorbable suture material. Thank you.